Thanks so much, folks, for being here. We're going to talk a little bit about obstructive sleep apnea. I'm going to cruise through a couple of slides for you, just reviewing data and some interesting pictures of apnea, and then treatment options, and then a lot of detail about this new Night Balance Lunoa sleep position trainer specifically. So the prevalence of clinically important obstructive sleep apnea, defined by this slide as an AHI of greater than 15 events an hour, captures 13% of men, 6% of women, 2 to 4% of school-aged children, and currently 4 to 5 million people receiving treatment, although if you add all that up based on the population, then we are only capturing treatment for a few of the apnea patients out there, which must explain why we all keep seeing new sick apnea patients, new mild apnea patients, new apnea patients, no shortage, and this documents that. Is there a reason that we're trying to identify these people and treat them? You bet. So comorbidities, consequences of obstructive sleep apnea are pretty extensive. Hypertension, heart disease, stroke being high on the list of comorbidities, increased difficulty managing diabetes, the impact of the apnea itself in terms of daytime sleepiness and functionality, relationships with obesity, and probably one of the more interesting areas, the difficulty losing weight when untreated sleep apnea is disturbing sleep quality in the background, mood, depression, headaches and reflux, and many other complications. The pregnancy complications is an interesting one. I keep trying in my town to fire people up to look for apnea and think about apnea in their pregnant patients, but that is a slow battle in terms of getting attention paid to that. So treatment of OSA improves outcomes. Probably not as much outcome information available as we would all wish to have, but there's a decreased incidence of motor vehicle crashes. I know Barb Phillips hates to call them accidents, so she calls them crashes, so I kind of agree with that. Hypertension improves, better control of atrial fibrillation, and if you're gonna cardiovert someone, better chance that their AFib is gonna stay under control if you treat the underlying apnea, and overall improvement in mortality in men, women, and the elderly. The airway is complicated. I guess that's a lesson back in 1981 when I started practicing sleep medicine that I didn't quite understand to the full extent. But if we're looking at the airway, the pharyngeal airway, between the uvula soft palate behind the base of the tongue and the vocal cords, is really a muscular tube. We call this sleep apnea, but in some senses it's an oxymoron since we don't have awake apnea because there's enough baseline resting muscle resistance in wakefulness that there's no airway collapse to any extent at all. Yet in sleep, this is the jeopardy zone, not protected by cartilage, bone, or other substance to keep it from collapsing. And as you all know, we have a rather dramatic drop in muscle resistance at sleep onset, and we go almost to zero across the board other than eye movements and tympanic membranes in REM sleep. So therein lies the rub. We have a critical area to get oxygen to the body that is subject to collapse at night. Quick visual on this. I captured this picture inadvertently trying to scan the clavicles in a mass at the clavicular level in a fellow with 72 events an hour. Clearly knew that he had significant apnea. And the radiologist, rather than giving me a CAT scan of his clavicles, used the pre-programmed sequence for his head and neck, and we captured the guy's entire airway, which is kind of an, oops, sorry, you've got a preview. Here's the button for that. So we see the pharyngeal lining here is bulked up. My ENT colleagues tell me even scoping someone, it's rather difficult to see the thickness of the pharyngeal airway even when you're looking, awake or asleep. Structural anatomy here, base of the tongue over here. So mouth would be here, pretty straight shot down through here. Esophagus is closed here. And watch what happens when he falls asleep in the scanner. In this 90-second scan, we managed to capture his airway awake and asleep. So there is airway closure at this level. I find these pictures to be extremely helpful for patients to understand what's happening to them, as well as the dynamic of the treatment options that we choose to use. So treatment options, positive airway pressure devices, which increase the ambient pressure in the pharyngeal airway, working as a counterforce to prevent collapse. Mandibular advancement appliances working to pull the lower jaw forward to make a little bit more space. Hypoglossal nerve stimulation, trying to stimulate the hypoglossal nerve to the tongue directly to move the airway, to move the tongue back away from and relieve pressure on the pharyngeal airway. Surgical procedures to the airway, which are fraught with a lack of good, robust, long-term positive beneficial effects. In fact, sometimes you can mask the snoring and do better at treating the snoring than you don't even know how much is going on, or at least you relieve the bed partner from complaining all the time while the patient may have worsening underlying disease. Body positioning devices and interventions for positional sleep apnea and weight loss, to name a few. So other things added to the list, there are nasal expanders. Last year at the meeting, I think I picked up 3 different samples of different kinds of expanders for people with tiny nares who have trouble getting air through their nose. Some of those people get managed before they ever get to us, because if they have such narrow passages that they're uncomfortable, they may have seen an ENT to manage it. There are Breathe Right strips that also expand the nasal passage by pressing on the nose. A chin strap to keep the mouth closed and in position, not one of my favorite things. The Provent or Theravent device, which was a little Band-Aid that went under the nose. And I think the fellow on the right here has one on here that lets you breathe in, but you have to push harder to breathe out. So it creates resistance on exhalation, which creates back pressure, which opens the airway up a bit. We found them a bit difficult to sleep with. They marketed this as an over-the-counter, the Therafend, as a snoring intervention rather than an apnea intervention. There's this Avio TSD device that's on the left screen, which you pinch over your tongue, pull the tongue forward with it, and it has sort of an edge, upper and lower, that gets captured between the gums and the teeth to keep your tongue protruded during the night. So I did run into someone last year who'd been using one for 3 years. I had never seen such long-term success with it, but he was quite happy, and on my dime, I studied him just to see if it was really working, and it actually was, but discomfort becomes an issue. There's an inflatable neck cuff. I just ran into my friend Jerry Cram, who studied that device to change positioning and impact apnea as well. And I'm sure many of your patients have tried these things in the course of time. So what I'm here to talk to you about today, though, more specifically, is this concept of positional obstructive sleep apnea, or POSA, which is the exacerbation of apnea when people are on their backs. And by definition, 2 times the amount of apnea on your back compared to your side meets the basic definition for positional obstructive sleep apnea. So we need to see at least a 50% or greater reduction in the apnea when someone flips from their back to their sides. And this was data proposed back in the early 1980s by Rosalind Cartwright, and the FAASM has published criteria on it as well that I'll highlight in another slide. Within the subset of patients with positional obstructive sleep apnea is a subset of people with exclusive positional sleep apnea, meaning that they have at least 2 times the amount of apnea on their back as compared to their side, but when they're on their sides, their index drops below 10 events per hour. This is the definition that we've latched onto. a few have been proposed, but this is the working definition of exclusive positional sleep apnea. Not completely normal, but pretty close. So the definitions and guidelines here, I had some stuff on the left, but mostly the FAASM came out with a treatment practice guideline on positional obstructive sleep apnea back in 2007. And at the time, the statement was as follows, that this is considered a second line of therapy or supplemental to primary therapy if there's a low AHI in the non-supine position. So there is a position statement about using it. It's 12 years old now, and devices such as the one I'm going to show you were not available at the time, and I think it was a very valid working approach to this, and many of you may have combined positioning therapy of some sort with your other interventions for your patient, sequenced in the opposite way. So these are just some of the references on and definitions of positional obstructive sleep apnea from Cartwright, Markland, and Medor, which are some of the more larger studies that have been done looking at this, and Cartwright's 1984 article as such. So why positional? Why are people worse when they're on their backs as compared to their sides? Why is this a specific subset of obstructive sleep apnea? Not clearly known. I ran into one small article in the literature suggesting that oropharyngeal tone changes in the supine position, making us more subject to collapse. People have talked about just the base of the tongue and pressure backward as well. But no good studies saying exactly why. Prevalence of positional sleep apnea, huge range, but a lot of positional sleep apnea. POSA prevalence in the literature estimated at 60 to 75% of apnea has some positional component to it, meeting the 2 times rule. Recent study by Heinzer, who we saw this morning, is that exclusive positional sleep apnea was present in 36 to 47% of OSA subjects, subdivided, so those are the ones who get down under 10 when on their backs. POSA can be diagnosed through a sleep study. It can be diagnosed through a portable study or an in-lab study as long as you have positioning data on the device. And the prevalence in practice, interestingly, tracks with the severity of the patients. And I'll show you a little bit more literature about that. This is just to say everybody's data doesn't say the same thing. Medor's study, the second one down here, and Tara Prapuk's study here both had looked at exclusive sleep apnea. Medor's criteria slightly different, 27.4% of his apnea patients, 47% of this group, and for positional, we're running from 56 to 75%. So I think the message in this is a lot of apnea has a positional component, and looking at it, if you break down and do your study with different criteria for the AHI, you see an interesting trend. So you get 36% exclusive apnea and 75% positional within that group if the AHI is just greater than 5. If you beef up your criterion and use an AHI greater than 15 or try to capture moderate apnea and above, you still have a fair POSA component, yet the number of exclusive positional apneas goes down, and the worse the apnea gets, the lower this becomes. So pretty significant drop between 16% with an AHI greater than 15, and if you pull into the severe range with an AHI greater than 30, you're dropping down to only 5% of patients. So message in that the worse the apnea gets, the less you see a clear positional component, and it becomes pervasive in all body positions. I think that's pretty intuitive. And there is the lighter bars to the right in each bar graph combo are women compared to men. So there is more of a positional component reported in women than men. So when you're looking. So there's a high prevalence of POSA in the general population. We've just looked at all these numbers, and the main characteristics of positional apnea population is overall lower AHI than the full population, and perhaps also a little bit lower BMI with less abdominal obesity when you look at men. So there's a couple of studies suggesting a relationship there. So tennis balls are the all-time favorite for doing this. I have a daughter who's an osteopathic physician and practices manual manipulative medicine. When I talked to her once about maybe making some t-shirts and sewing a pocket in the back and putting our logo on the front for people to put their tennis balls in, she had a heart attack over the whole thing. You don't want to be able to roll over and torque your back on the device you're trying to treat another problem for the patient with. And there's been, I think, a plethora of these devices over the last 5 to 7 years. You can see them at the meetings, different sizes and shapes. When we use these, which we've been known to do at times, I generally add suspenders to them to prevent them from swiveling, particularly when we're looking at thinner patients that might not have a very definitive spot for it to stay locked into. So lots of creative ideas in that department. Limitations of what's out there now. Discomfort is one. You know, if you strap this thing to your back and you put your suspenders on, one, are you going to be willing to do that every night? And two, are you going to be able to cuddle the way you want to cuddle, and all those things about it. Disruption of sleep architecture. So the mechanism of all of these mechanical devices that we just looked at is to bump into it, literally, as you roll over onto your back. So you've got this device here, you're good on your side, roll on your back, wakes you up. Eventually, one would like to think that Pavlovian conditioning would come onto play, and you would learn not to roll over on your back and wake yourself up repeatedly. So we do depend on a disruption of sleep architecture to wake up and shift position because of the discomfort of rolling into it. I have, by the way, seen a patient roll over on his back and get position 0 with one of the more robust of the mechanical devices because he had one of those Tempur-Pedic mattresses, and the whole lump sunk into the Tempur-Pedic mattress. So I was stunned that he didn't get conditioned at all. So you can acclimate to the constant stimulation. So there's some people's brains are going to say, nope, I'm going on my back anyway. You can keep waking me up till the cows come home. No objective adherence data. So this becomes a very important issue with the FDA and with considering this new device that I'm going to talk about, a medical device to treat a medical condition. We have to be able to see if it's working and if people are using it. No clear guidelines on the duration of treatment. How long does it take to entrain someone when you put them in a device? I mean, how many of you will have a patient wear a device for a month before you look at them again? 2 months? 3 months? Everybody's here because they never use a positioner. So we used to tell people to keep it on for at least 8 weeks, and then we used to take it off because we thought they were all going to take them off in the long run because they're bulky and uncomfortable, and then study them in 2 weeks and see what we've got. But then there's still the question of, should you study them again 3 months later? Do you depend on a bed partner hearing the snorting and gasping? So no clear guidelines on duration of treatment to entrain, need for continuous treatment. So I know that they're advocates of, if you're going to do this, you have to do it every night. No clear guidelines is the interval to restudy, as I spoke about. So the new product we're talking about is this Lunoa device, night balance Lunoa device, that is sort of a wider memory stick size, and you can go by the booth and see that. We were part of the clinical trials, so we have a lot of facility and history using the device. And it's got a display screen so the patient can see what's going on. I'll give you a little more shots of that. And it just fits into a small charging base at night, during the day to get recharged. It zips into a zipper pocket in a comfortable belt on the patient. So it's designed to withstand repeated use. It's expected to live at least 3 years, and you can wash the strap when you're using it. and it is FDA approved. Its FDA approved indication for use demonstrates that the product is primarily used to serve as a medical device for the treatment of positional sleep apnea, not specifically the treatment of snoring, as a lot of the other things that you've seen here. So how does it work? You turn the little baby on, zip it into your pouch, strap the strap around yourself, and it gently vibrates when it senses an arousal and the initiation of any shift in position. So it gets turned on and slipped into the pocket, and patient goes to bed, and in the morning can review the screen. As you know, our patients love to see the screen and how they did the night before. They get information about the percent of time they were on their back, stimulations, number of stimulations, and they can also look at improvement trend. When they put it back in their charging base, the information Wi-Fi's to a central site where you can get on and score how is your patient trending and doing over time. They switch it off and stick it back in the charger. So this is an example of 30 days and the trend. So the top graph here is, by the way, when you first put it on, it samples and watches for 2 full days. There is quite a fair-sized brain in here. Maybe it's a Drosophila brain from this morning that's in there, since those are good brains, huh? But there's a fair-sized brain in here, and it is going to sample and look at what you're doing to get a little bit of an idea of your habits. It will report the percent of time you were on your back. So this patient was on his back for 28% of the time over the first 2 sampling days. Over the next 9 days, it also watches patterning and tests different vibratory signals. So there's an issue of you don't want your patient to adapt to the signal, so this changes itself so that you don't learn to ignore it. And what you're seeing here is the percent of time on back over a 30-day period of time. And we're down to just a few percentage points there. And this is the compliance data, and a really important issue with getting insurance carriers to cover this for your patients, and for this to be considered by Health and Human Services a medical intervention, so we can see that the patient wore the device the entire time. So what evidence do we have that this does any good? So this sleep positioning trainer, the Lunoa Night Balance device, has 8 peer-reviewed publications in medical journals, and I'll show you at the end that the trial that I participated in here in the US has been accepted for publication at the Journal of Clinical Sleep Medicine, is now quite yet, but on its way. So the clinical evidence base, from a clinical perspective and not a trial perspective, the device was a Dutch woman's PhD thesis, kind of cool, and they looked at 75 Night Balance Lunoa users for an average of 2.2 years and showed very consistent results in terms of consistent usage and consistent feeling that this is subjective, but was doing the job for them, with less sleepiness during the day, less fatigue during the day, more refreshed in the morning, and less snoring, choking, gasping from a subjective perspective. I'm going to interject here we're clinicians, so a little bit of a case study for what do these people look like for you, and then I'll come back to a little bit more of the data. So this is a 49-year-old gentleman, BMI 27.3. He's a little overweight. He's also a little muscular. Neck circumference 15.5 centimeters. Complaint is loud, disruptive snoring. Subjective daytime sleepiness on an analog rating scale. How sleepy do you feel on a scale of 0 to 5? He scores a 3. How likely are you to fall asleep doing A, B, or C of the Epworth? In the normal range at 4 out of 24. Past medical history, asthma, reflux that he's being treated for, carries a diagnosis of adult ADD, which I'm always suspicious of sleepiness for, and tinnitus. He's recently, over the past 6 months, gained 10 to 15 pounds and had kept his weight in check prior to that. He had a portable home apnea screening test, just highlighting some of the information. We calculate what we love to call a quiet valid airflow recording time, subtracting movement artifact out of these portable tracings of just a little over 7 hours. His overall respiratory event index, moderately abnormal here at 26.8. Fairly significant DSATs at 83%, and huge positional component. He was on his back 287 minutes of those 7 hours and had a severe supine REI of 37 per hour, in contrast to 5.3 per hour on his sides over a little 2¼ hours plus a little bit. So this fits the definition of exclusive positional obstructive sleep apnea. What does it look like? He looks horrible on his back. I'm sure you have all seen these with just, this is a 10-minute sample with repetitive apneas. You can see the oxygens drop, you can see the pulse rate variability, and the clusters of snorting and gasping with this when he's on his back, with SATs dropping down to 84%. Lovely, lovely 10-minute sample to grab where you can see him shift onto his right side, which is the only side he slept on that night, with very nice, even respiratory pattern, quieting of the oxygen sat, nice and steady, and quieting down in the pulse rate variability as well. And this is him settled in on his sides, breathing nicely with very little, barely perceptible. I never know when the signal's this low on these portables, whether that's breathing noise or actually snoring. So very good example, and what we would consider to be a prime candidate for treatment with a positioning device that you can track and show that he's being treated. He has significant apnea. He's got tiredness impacting his day. We want to be sure that we're treating him well. So the positive study was a national trial that was run and finished in June of last year. Sites are in turquoise blue, scattered a little bit more on the east than the west coast. And the study design. So this was a prospective, multi-center, randomized, crossover trial comparing 6 weeks of treatment of the night balance sleep positioning trainer with 6 weeks of treatment with an auto-adjusting PAP device. So this was sponsored by Respironics. Everyone got a very nice brand new DreamStation machine, standardized in that regard. And there was some standardization of mask choices as well. There were 11 sites, 117 people were randomized, 110 completed, and I'll show you where the other 7 went. And it was randomized as to whether or not they got the positioning trainer first or the APAP device first. And the primary endpoints were efficacy of treatment based on the baseline AHI of the SPT group versus the APAP group, and adherence after 6 weeks of home use with each. So those were the 2 primary endpoints that we looked at. And the methods, they were randomized. They had 6 weeks of each in a random sequence. But the important thing is that there were 5 subjects who withdrew in the first 6-week portion of the trial. So we had 59 people who were randomized first to the APAP and 58 to the SPT, so it was fairly well balanced. 5 subjects withdrew in the first 6 weeks, 3 voluntary decision. 1 was CPAP, 1 moved, was in the military, and 1 was using the SPT device. And then 1 got booted by the investigator for non-compliance. And then in the second 6 weeks of the trial, 2 subjects withdrew, both voluntary decisions, 1 from each group. So nothing particularly telling in that other than the adherence to use of both was really pretty good during this trial. What did the demographics look like? Mean age of 51, ranged up from 24 to 76, and close to 60% were male. The other thing that's interesting on here, BMI, average 30.3 plus or minus 5, range 19.4 to 53.5. So people were not excluded when they were extremely morbidly obese. And the mean AHI was 21.2, and that ranged from 9.5 to 55.6. They had a baseline Epworth and a follow-up Epworth sleepiness scale during the study to assess sleepiness at average 10 plus or minus 4.9 with a range of 0 to 24. If their Epworth was below 10, they had to have a certain amount of apnea and differential between it. If they didn't have sleepiness, there was slightly more stringent inclusion criteria if they weren't overtly sleepy. So results here, I'm going to display for you a couple of ways. I'll do them in this table form and then as bar graphs. But the primary endpoint was change in the AHI. And so the AHI was reduced to, so this is not change, it was what it was reduced to, absolute value of the number, 7.29 events per hour with the sleep position trainer, and 3.71 with APAP. So APAP remains slightly more effective in normalizing the AHI in a greater group of people. But if you look at the second criterion for primary endpoint was adherence. And this is where the adherence data shows that they got an hour more usage time, an average of 5.8 hours with the SPT versus 4.8 hours with the CPAP device. So a little bit of a trade-off, slightly less reduction in the AHI, but a robust increase in the amount of time that the patients use the device. And the question was, the question posed by the POSA study, so to speak, was to prove non-inferiority to APAP. There was never a desire to show that this was more effective than APAP, but just to show non-inferiority. And when we look at those numbers, the mean difference between the AHI passed the non-inferiority at 3.6 per hour, and the adherence mean difference of 58 minutes passed as well. So it was shown to be non-inferior when studied in a group of people with positional sleep apnea. This just shows the same thing in bar graph format. We have baseline. The middle graph is the SPT and the CPAP. And adherence, a little greater in the SPT group, huge, much bigger range of adherence in the CPAP group overall. So as I said, accepted for publication in Journal of Clinical Sleep Medicine. It was accepted in February. We're expecting it out sometime soon. And the AHI reduction by the Lunoa system was not inferior to APAP in patients who were specifically screened and shown to have positional sleep apnea. Adherence to treatment was significantly better with the Lunoa system. Average nightly use by minutes and percentage of nights with more than 4 hours of treatment, the Medicare standard. And patients had fewer arousals with the SPT compared to with the APAP device when we looked at the data from their sleep studies at the beginning and end of each treatment section. Other outcomes, sleepiness was similarly improved on both the night balance and the APAP devices with the subtleties of differences that I've just shown you. A greater proportion of the POSA patients felt the night balance device was easier to use, easier to adjust to, and more comfortable overall. Let's see, time-wise. I have one more case I wanted to show you just to illustrate another case of positional apnea, but when you might vary and decide we're going to go back to the ground and use standard treatment. So this is a 41-year-old, 6 feet, 280 pounds, BMI is 38. He presents with disruptive snoring and gasping, bruxism, reflux, morning headaches. Data from his in-lab study on this occasion, he had a total sleep time on the left of 482 minutes. He had 111 minutes on his back, validated by the video on the study, and had an overall moderately abnormal respiratory disturbance index of 17. His AHI was 16, and he had a non-supine RDI of 10 and a supine RDI in the severe range at 41. So he meets the criterion for exclusive positional sleep apnea. He desats down to 86%. He had 7 minutes of sleep time below 88%, which is a number some of you probably like to look at. And we do a subjective rating of his snoring was moderately loud on his night in the lab. So additional history becomes important here. So first, he is status post uvulectomy, turbinectomy, and deviated septum repair 3 years ago. So there's no contraindication to using a positional treatment in somebody if they've been previously operated on. So that does not form a contraindication. But his Epworth is 14 out of 24. He's complaining like the dickens about his tiredness. He's just recently been diagnosed with type 2 diabetes over the past year and now requiring insulin for management and still has a pretty rotten hemoglobin A1C of 8.2. And he's at his peak life weight and even with effort is having trouble losing weight with diet and exercise. So I know Sushil Patel and his group just published a treatment guideline for patients with sleep apnea who are sleepy, suggesting that CPAP is still the best route to go. Would this patient be a viable candidate in the future to consider for positioning once he's stabilized, once some of the weight is down, once his blood sugar is under better control? Sure. But maybe in this situation, treatment with CPAP still may be the first thing to do. So where can we use this? We can use the positioning device solo in patients with positional sleep apnea, particularly exclusive positional sleep apnea. We can use it as an add-on treatment in patients requiring very high pressures to manage the treatment on the back versus the side. We can use it as an add-on therapy with the use of the mandibular advancement appliance if there's residual positional apnea in that setting as well. So SPT, the sleep positioning trainer, non-inferior treatment efficacy and greater adherence, suggesting that SPT is an effective treatment for this group. And that is my conclusion. So there is an additional, there's a webinar that was produced by Dr. Richard Berry and myself and others, Dr. DeVries, who has done seminal research in positional apnea that you can log into at this website. I'll just leave that on for you if you're interested in more detail, more cases, and more of the basics. Happy to field any questions if anybody has any questions at this point.